Good evening. My name is Shireen JG. I'm a consultant cardiologist at the Royal Melbourne Hospital. Thank you for everyone for attending this webinar on this evening on heart failure, improving management and reducing readmissions. I'd like to start with acknowledgement of country. The Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place. The Wurundjeri Woi Wurrung people, the Boon Wurrung people, and the Wethaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just some housekeeping slides. So all attendees are muted. Please ask questions via the Q&A box only. And Q&A will be at the end of the presentations. We will, at the end of all of the presentations, we will invite you all to unmute so that we can have a live discussion. This session is being recorded and questions will be asked anonymously to protect your privacy. Please ensure that you have joined the session using the same name as your event registration or phone number if you have dialed in. So NWMPHN uses Zoom's participant list to mark attendance and certificates, and CPD will not be issued if we cannot confirm your attendance. If you are not sure if your name matches, please send a chat message to NWMPHN Education to identify yourself. So it gives me great pleasure to introduce our speakers this evening. So we have with us Associate Professor Leanne Grigg. She's a consultant cardiologist and head of the cardiology service and head of the adult congenital cardiac service at RMH. And Associate Professor James Wong, who's a consultant cardiologist and director of the Echo Lab and heart failure lead at RMH. We have Dr. Sue Hookey, a general practitioner and director of GP liaison at RMH. Jessica Borchich, heart failure clinical nurse consultant at RMH. And Joanna Young, heart failure clinical nurse consultant at RMH. So to run through the objectives of this session, our goals are to discuss key heart failure updates in diagnosis and treatment, our heart failure service at RMH, what we are doing at RMH to reduce hospital readmissions, and in particular, how that is relevant to primary care, the Safer Care Victoria projects we are participating in, what online platforms are currently available to improve communication. And we really want to understand from you in the discussion at the end of the presentations, what the challenges are in the treatment of our heart failure patients, what you think the gaps are, and how you think that we can improve how we communicate. So without any more delay, I'd like to introduce James Wong, who will start off with our first presentation. Thank you, James.
Let me just get my screen organized. Okay, can you all see that screen okay and hear me okay? Good, okay, thank you so much, Shireen, for introducing. I'm actually delighted to talk about heart failure once again. It's one of our pet subjects here, and we do have a strong passion in actually dealing with heart failure because we do see a lot of strong benefits in what we then do and see the actual benefits in actually making our patients feel a lot better. I just want to start off with a survey that was actually recently conducted amongst general practitioners, and we wanted to find out exactly what the goods and bads was about dealing with heart failure patients and also how we can best co-manage our patients with you. And we have found that, we have a strong sort of idea of how to diagnose heart failure. But there is some sort of lack of confidence in terms of how to deal with some of the actual drugs that we're actually using in heart failure land currently. So the question now is really how GPs can best co-manage heart failure with specialists. And this evening's talk is designed to look at the diagnosis of heart failure, and help you to understand how we determine the type of heart failure and its trajectory, somehow initiate the guideline-directed treatment that has been utilised all over the world, both pharmacological, patient education, some sort of rehabilitation, and importantly, end-of-life care as well. Just a snapshot view of what goes on in heart failure in Australia. 511,000 patients are diagnosed every year. About 158,000 admissions per year, representing about 1.1 million bed days in hospital. And that does basically mean that there is a significant death toll related to about 61,000 heart failure deaths per year in Australia alone. And the whole sort of economic burden comes up to be close to over $3 billion of healthcare dollars per year required. So over the next 10 years, there's going to be an increment of the number of heart failure diagnoses made. And I think it's important to understand that because the burden will increase over time. What we are seeing is that despite the best of our care so far, about 9 out of 10 patients who have standard of care still have symptoms of heart failure. And about 5 out of 10 patients with heart failure will die within 5 years after the diagnosis. So after being admitted to hospital with heart failure, there's actually two known really high outcomes. One is that there's a huge high increased risk of death, and there's an increased risk of readmission. So after the first hospital heart failure admission, there's a mean survival of 2.6 years. And as we start to see further admissions of heart failure, second, third, and fourth heart failure admissions, we see that the mean survival falls down to less than 1.5 years, or down to 1.3 years over time. So the other burden that we also see is the avoidable hospital admissions. This is different to the ones that actually come into hospital with heart failure as a de novo diagnosis, but we're talking about patients who could have been prevented coming back into hospital for no good reasons, perhaps. And so these are termed as the avoidable heart failure admissions. So you can see that the across the board cardiac conditions rank number 2 in the avoidable heart admissions in hospitals. And the burden is actually quite wide. It's not just in the cities, it's actually 7-fold higher in the rural territories compared to the actual metropolitan area. So we are dealing with a fairly big group and a bigger group in the communities outside. I just want to point out to you, there are some heart failure guidelines, and the National Heart Failure Foundation has issued one back in 2018, which we had a chance to help co-write. The last one was basically back in 2011, and it's a worthwhile thing to actually look at some point in time. We also want to point out Your Health Pathways, which is an extensive, comprehensive overview of the diagnoses in the treatment and investigations of ongoing management of patients with heart failure, and it's an excellent resource to go after as well. I think I just want to turn quickly to the risk factors that are involved with heart failure. Listed here are some of the risk factors, and I think it's worthwhile considering heart failure when you do come across patients with these underlying conditions, patients who are over 65, who are diabetic, hypertensive, atrial fibrillation. I think you all probably know that kind of combination of features that actually lead to incipient heart failure at a later time in their lifetime. The causes are quite extensive, and it's important to understand the causes because the prognosis of heart failure is largely dependent on this, and also the treatment is also largely dependent on this as well. It's important to diagnose coronary artery disease, for instance, because we can treat that. We can make the coronary artery perfusion a lot better and improve heart function and also longevity. Hypertension, valvular disease are all fixable problems if we get to them soon enough. There also are some reversible things, and I think it's important that anyone who has heart failure or an exacerbation of heart failure, we just really need to step back and understand what had happened to them to actually decompensate, because if we don't find that underlying cause, this patient's going to come back again with the same problem. So it's important to actually dig deep down, as deep as you can, and underline exactly why this patient particularly had come back into hospital. So to diagnose heart failure, it is a symptom complex of symptoms and signs that generally occur on exertion, but can occur at rest. secondary to an abnormality in the cardiac structure or function that impairs the ability of the heart to fill with blood at normal pressures or eject blood sufficient to fulfill the needs of the organs. So this is a schema which was actually put forward in the 2018 National Heart Foundation guidelines of how to diagnose heart failure. And obviously the history and examination is important. And I'll allude to some of the actual testing that gets involved in terms of echocardiograms and also BNP. So this is an important thing to start to differentiate the type of heart failure that we're actually dealing with. This has now been simplified into a three-step process. This is what we call the universal definition of heart failure. So number one is symptoms and signs of heart failure caused by a structural or functional abnormality. And the symptoms and signs could be current or past, and the structural abnormality can be diagnosed on the use of an echocardiogram. If we then added in either a natriuretic peptide elevation, that's a BNP, and these are the actual boundaries of which we diagnose heart failure listed in the slide here, or there's evidence of pulmonary congestion or systemic congestion as evidenced by a chest x-ray, which was abnormal with pulmonary edema, or elevated filling pressure by an echo or hemodynamic measures such as a wedge pressure or under exercise conditions. So that simplifies the concept of heart failure. So I think it's important to understand that it's a complex base. It's not just ordering an echocardiogram and seeing the echo shows an abnormality and therefore has heart failure, because you can certainly have heart failure with a normal ejection fraction, as we're going to talk about soon. BNP is a very useful test, but it's unfortunately a costly test, and it's not funded by Medicare currently. And I think this is one of the things which are highlighted by the survey as well. I think it's a useful test to help to rule in and to rule out heart failure. So if we ever use BNP, it's a useful test, but using it sparingly at the in the right patients. Just to allude to, there are two types of BNP that you can measure at. There's a B-type BNP, or there's an NT-proBNP, and they do have different boundaries of normality. So it's important that you get to know which one that you're using. Understand also that NT-proBNP is useful when people are taking drugs like Entresto, whereas the other type of BNP can get quite elevated. So changes in BP can also be affected by other things, not just by heart failure. Acute pulmonary embolism, pulmonary hypertension, airways disease can also increase these things as well, but can actually be undercalled by hypothyroidism, people who are obese or sometimes on diuretics and ACE inhibitors. So just to know that there are some issues with that. This is an echocardiogram. I'm just see if we can make this go of a beating heart. This is an ultrasound. On the left-hand side of the screen here, you'll see that the function of the heart's quite normal. And then as we actually move across to these screens on the right-hand side, you can see the same heart configuration, but the squeezing part of the heart is actually quite reduced. So this is where we start to measure the ejection fractions. So the ejection fraction is really estimating how much of the proportion of the blood pool in the left ventricle is actually ejected out of the ventricle per squeeze. So then if you can push out more than 50% of what's in the ventricle per squeeze, that's considered normal. So what's normal in ejection fraction? That all depends on where you live. So in Australia, we've decided that we're going to call a reduced ejection fraction anything under 50% and something whose preserved ejection fraction over 50%. In America, they have, and in Europe, they have a reduced EF, and there's a mid-range EF between 40 and 50%. And then there's also another concept where we talk about the improvement of EF as well over time. So that does somehow complicate things in a little bit way. So I think here, I like to make it simple and keep it simple as best as we can. So in terms of diagnosis, it's important to get the structural signs and the symptoms and signs, the classification of the type of heart failure, that is heart failure with preserved ejection fraction or heart failure with reduced ejection fraction, and its trajectory, whether it's on new onset, worsening, improving, persistent, or in remission. So the word persistent now replaces the word stable, and the word remission replaces the word recovered. It's important to understand who to refer for patients with heart failure. So urgent referrals, anyone who's got ongoing chest pains, acute pulmonary edema, worsening symptoms without under previously good control, that's actually escalating quite rapidly. Oxygen saturations which are deteriorating, hemodynamic instability, syncope, pre-syncope, myocardial infarctions, or having become pregnant and being short of breath and being postpartum is important to get them referred quickly. Non-urgent ones, new diagnosis of heart failure, which hopefully that can be managed with some diuretics initially, but I think it's worthwhile to have most of the heart failures looked at by a cardiologist at some point in time, then to explore the underlying causes of heart failure, maybe understand that there are ways of actually dealing with it as well. So what are the actual medications? I think over the past number of years, there had been a very slow evolution of heart failure drugs. And you can imagine that we started off with diuretics. We then found some benefits with the use of ACE inhibitors or angiotensin receptor blockers. And then we also had beta blockers and MRA, such as the aldosterone antagonists. And there was a big lull for the last 10 years where there's nothing basically happening. So we had those 3 levels of drugs given to us, and we've been using it for such a long time, and nothing happened for a long time. And it's only in the last couple of years that we've been actually getting the benefits of some important drugs coming through, such as the SGLT2 inhibitors and also the Entresto, which is the neprilysin inhibitors, all of which have received a Class 1 recommendation for its use for patients with reduced ejection fraction here. This is a schema by the European Society of Cardiology in heart failure, looking at the use of these drugs when we're managing these patients. So up in the green section here, you can see that everything's all lumped together, and we somehow starting to work out that we like to think of all those 4 groups of drugs as equally important in the use of heart failure, and starting them earlier and up titrating them to the appropriate doses is important. Further downstream from that is the use of ICDs when people are not improving the heart function over 35%, and we can talk about that a bit later if need be. So in August of this year, the Australian consensus updated their guidelines in terms of how to treat heart failure. And you can see here on the top green bar here, we've actually put all of the 4 pillars of those drugs on equal standing, because we believe that we need to have every patient on heart failure considered for all of these drugs at all times. The difference between our standard and the European standard is that we've actually divided them up into congested forms and euvolemic forms. And the beta blocker is best to use when the congestion has been taken out. So in other words, if they are congested, we need to dry them out a bit more. You can start them on an ACE inhibitor and an SGLT inhibitor as well early in the piece. Add the beta blocker on once they've actually been decongested. And once they've actually started on these drugs, we really, really want you to up-titrate them to the appropriate doses. And I think if there's any questions about up-titrating, it's important to ask this evening, because it's a difficult thing to actually give you a formula for, because every patient's a little bit difficult and different, because sometimes people don't have enough blood pressure, sometimes they may not have enough potassium room to work with or renal function room to work with as well. So these are the nuances in actually using these drugs. Previously, when we used these drugs, we started off with an ACE or an ARB, we added in the beta blocker, MRA, then Entresto came along, and now the SGLT inhibitors have been the actual new kid on the block here. So these were sequentially added, and they were sequentially added because all the actual drug trials were actually done in a particular order. So basically every time there's a new study being shown that a new drug is actually of some benefit, it's actually compared with existing treatment. That's why it's been laid that way. But I think now it's important to understand that the actual treatment for the symptoms of heart failure require an early start of all these drugs. And I'm just going to put up some tables here about up-titrating ACE inhibitors. There's a lot of ACE inhibitors around. I just use the top 2. That's my personal preference because I can spell them and I can understand and remember the dosages of those guys. So, and likewise, the ARBs, they're my top two uses, and equally speaking, there's no reason why you cannot use any other angiotensin receptor blocker in that situation either. In terms of beta blockers, up-titrating them is important, and I think if anything that you up-titrate the most and to the maximal levels would be the beta blocker, because you do get the best bang for your buck with the beta blocker compared to the other agents themselves. And the new kid on the block, Entresto, we usually start them on the 49-51 milligram dose for patients who are reasonably robust with a reasonable blood pressure, but if their blood pressure is on the low side or we're unable to have them on a higher dose of ACE or ARBs, then we can actually start them on a smaller dose and up-titrate them as rapidly as we can according to the blood pressure and the tolerance. This is a slide just to give you a perspective on to how beneficial each of those classes of drugs might be. So for instance, the angiotensin receptor blocker has a reduction of mortality around about 13%, the ACE inhibitors around 16%. The best bangs for your buck comes with the beta blocker about minus 34%. Overall. But I think if we can combine all of these things as best as we can, we get the best benefit for our patients in the long term. So what we're trying to do here is to give them drugs which are prognostically beneficial, that is, that do make them live longer, not necessarily make them feel better alone. So the feel better drugs alone are things like frusemide, which actually takes away the fluid and decongests them and makes them feel better. But consider that a bit like a pair of crutches. And because once we can get them on these proper drugs, then we can pull back on the diuretics in the longer term and use drugs which have got some prognostic benefits to them. Finally, I just want to talk about the nuances of actually using all these drugs, because I think there is no fixed rule about what we should start off first and how we should manage them, because I think sometimes we are hampered by someone's blood pressure being sometimes low. Sometimes they may have a very fast heart rate, which the beta blocker would be a better option to start off earlier. Sometimes if the renal function is actually poor, then we'd be very careful about starting an ACE and ARB in big doses or an MRA itself. So these are the kinds of nuances that we are thinking about, and this is how this strategic phenotype of the presentation of the patient is actually useful to understand, because it will actually then customize the actual type of drugs that we are using, say beta blocker in preference over an ARB or something like that over time. So this is something that is a bit hard to actually prescribe in an algorithmic form, but I think it's something that's worthwhile considering. And this is where we can certainly help you out understanding and actually sort of managing your patients outside of hospital as well. So finally, I think the important thing is to understand advanced heart failure treatment options. Certainly, we like to maximize the heart failure medications in hospital. We sometimes may need to resort to inotropic support, and in some cases, a ventricular assist device, that's the VAD, and then ultimately transplantation if things don't work out very well. And I think I just want to point out that palliative care and hospice care is an important aspect of the management of the patients. And it's sometimes that we don't do this very well at all, or we are hesitant in actually starting to talk about this issue with some of our patients. But I think, when hope is not part of the plan, we need to start discussing palliative care and hospice care for them and end-of-life care in a equally valid way with the patients themselves and their carers alike as well. So thank you so much for listening tonight, and I'll be happy to take on any questions that you might have at the moment.
Great, thanks so much for that, James. So I can't see any questions in the Q&A box at the moment. Although please do put your questions in. We do have a discussion session at the end of all of the presentations. So in that case, what I might do is now introduce Jess Borchich and Joanna Young, our heart failure clinical nurse consultants at RMH. And Jess and Jo will now give us an overview of our services, the heart failure improvement projects we are involved in, and how that is relevant to primary care. Thank you, Jess and Jo.
Hi there, everyone. I'm Joanna Young. I'm one of the heart failure nurses, as Shireen said. I'll be speaking about the heart failure service at Royal Melbourne and the heart failure nurse role, and how we support the patient journey and work towards best outcomes.
Jo, just a quick mention, you're on presenter mode. We can see your presenter mode.
Jess has got the slides up there.
You're on presenter mode.
If you just click swap displays at the top there, it should swap it over.
Just in the up, yeah.
Thanks, Jess. So this is just a brief overview of the Royal Melbourne Heart Failure Service. This existing model is currently undergoing some further development with Safer Care Victoria initiatives, which Jess will talk about soon. However, most relevant is on the left-hand side, the cardiomyopathy service, which has been for our heart failure and cardiomyopathy patients admitted under cardiology. So patients are seen, these patients are seen on the general cardiology ward round. They have a lot of input from the heart failure nurse. And then on discharge, they're referred to the cardiomyopathy clinic for long-term care alongside their GP. And then discharged if considered stable, but they're often under our care for many years. Until the current developments, our patients with heart failure admitted under general med have not had specific heart failure input during the admission. And these patients have been supported by GPs and HARP if eligible post-discharge alongside general med clinic or private cardiologists. Thanks, Jess. An advantage of the cardiology model was there was a lot of involvement with the heart failure nurse. So many aspects of heart failure management, including education and non-pharmacological interventions, take time to implement and require continued reinforcement. So it is beneficial to have a nurse to help facilitate this. Our patients are seen by a heart failure nurse during admission, often more than once, and then they receive a phone call 48 to 72 hours post-discharge to ensure they understand their heart failure management and medications, and it also provides an opportunity for them to ask questions. The nurse-led education, so studies consistently show that heart failure nurses play an important role in the care of patients by providing education, which is fundamental in heart failure management. Heart failure nurse-led education has shown to significantly reduce the risks of all-cause readmissions. The heart failure nurse role, though, extends further than the education of our heart failure patients and plays a larger role in discharge planning to promote smooth transition from hospital to home, then the post-acute care phase with follow-up phone calls, liaising with GPs, heart nurses, and other members of the patient's multidisciplinary team, and cardiac rehab. The heart failure nurse continues to be a key contact for the patient and their community team throughout the patient journey, promoting engagement in heart failure care and monitoring those patients at higher risk of deterioration where we escalate and intervene. We put a lot of emphasis on the heart failure action plan, which patients should know very well by the time they walk out our doors. They need to know to speak to their GP or heart failure nurse within 24 hours if they notice symptoms of fluid retention or notice that their weight has gone up or down by more than 2 kilos or more over 2 days. As we know, early recognition and intervention prevents further deterioration and can avoid a hospital admission. With the goal of keeping patients cared for in their home and to achieve patients' best outcomes, GPs are integral for successful management of patients with heart failure in the community. Collaboration, shared care, and a multidisciplined approach care is the recommended approach to facilitate patient care in the community, minimising the risk of readmission. The heart failure nurse is a key contact for when concerns do arise in the community, when a patient is recognised as deteriorating, so we are able to escalate and intervene. This may require liaising with the cardiologists and increasing diuretics for a few days, or we could have the patient seen urgently in cardiomyopathy clinic. They may require a referral to hospital in the home, or we may need to organise an admission. A number of benefits of having a heart failure team involved in the care of patients in the community have been identified, and we hope that it will reduce some of the pressures on GPs and reduce hospital admissions. It provides reassurance that your patient with a diagnosis of heart failure will receive guideline-directed specialised care. And we also aim to keep GPs updated with patient care by providing documentation of each clinic appointment. The benefits for patients include support for engagement and adherence. We can break down the fear of the term heart failure and this alleviates the potential anxiety or worry patients and their carers have. It empowers patients to see their diagnosis as something it is possible to live with and live well with. We can provide direct and on-demand advice and support when required. We provide education that is ongoing throughout their whole heart failure journey and individualised advice so that strategies to manage heart failure can be implemented more easily. We assist with risk factor modification and reduce the likelihood of requiring hospitalisation. For referrals, we accept all referrals with confirmed diagnosis, and the referral is just through outpatients. And this information is found on the Royal Melbourne website.
All right, so thank you, Jo. So my name's Jess and I'm the other heart failure clinical nurse consultant and also the cardiovascular ambassador nurse. And I'll be speaking to you today about the projects that are being run by Safer Care Victoria. So the Heart Failure Collaborative and the Cardiovascular Ambassador Project, and also a bit at the end about the Heart Helper Project. So just a bit of a background. So Safer Care Victoria are collaborating with 19 other health services to participate in both the Heart Failure Collaborative and Cardiovascular Ambassador projects. And these two projects are looking at reducing hospital readmission rates by 20% by June of next year. As we know, readmission rates vary quite widely across Victoria, ranging anywhere from 13 to 33% at 30 days. And data suggests that up to 2/3 of these could be preventable. Through these projects, we're also looking at monitoring the length of stay and hopefully reducing this as well. So just going through the project scopes. So for the Heart Failure Collaborative, we're looking at cardiology patients with a primary diagnosis of heart failure. And the Cardiovascular Ambassador Project really looks at cardiology, general medicine, and the acute medical unit patients. And in-scope patients are any unplanned hospital readmission. And as you can see, we've got some criteria there for out-of-scope patients. So looking at the three projects that are running concurrently, we've got the Heart Failure Collaborative, the Cardiovascular Ambassador Project. Both of these projects have an aim to reduce readmissions by 20%, just with slightly different timelines and with different implementations. And the Heart Helper project is mainly aimed at reducing emergency presentations and improving patient-reported outcomes, with a similar scope to the Cardiovascular Ambassador project. Just looking at the Heart Failure Collaborative driver diagram, as you can see, there's quite a number of drivers that we're looking at, but in particular importance for GPs is we're looking at the 5 steps to safe heart failure discharge. and organising that medical review within 7 days of discharge, that patients are encouraged to book an appointment with their GP. Also ensuring that patients understand their action plan and how to seek help. And we're also looking at improving the coordination and communication during the transitions of care from primary to secondary care. So what we're actually implementing in the hospital at the moment is a standardised care pathway for all heart failure admissions across cardiology, general medicine and the acute medical unit. So we're looking at investigations that are appropriate to diagnose and classify heart failure, ensuring that patients are on guideline-directed medical therapy where appropriate for the treatment of their heart failure, including iron infusions, referral to the heart failure clinical nurse for inpatient review, and ensuring thorough education and discharge planning is provided to all patients, including referrals to community programs, follow-up phone calls like Jo mentioned, and the 5 steps to safe heart failure discharge. So looking at the 5 steps, and in particular steps 2 and 4 are quite essential for GPs to be involved with, is making sure that patients can follow their action plan and are able to contact or get in to see their GP quickly when they're deteriorating, as well as organising a medical review within 7 days of discharge. And the reason for this is to ensure fluid assessment, review of any medications and changes, and make sure that GPs are aware of recent admissions and helping to facilitate any up-titration of medications as required. We've also implemented a new heart failure telehealth clinic, which is combined for cardiology and general medicine patients and allows the early review of these patients within 2 weeks post-discharge. The main aim is for the up-titration of heart failure therapies for this clinic. The clinic is accepting patients who have had a recent admission with heart failure, a BNP rise, and HFrEF or HFpEF with a clear precipitant such as AF. The patients are seen fortnightly, alternating between the clinic and GPs to facilitate the up-titration of guideline-directed medical therapy and complete fluid assessments and monitor renal function. This is a short-term clinic that will see the patient for 90 days and then they're discharged back to their primary care or private cardiologist or clinics, cardiomyopathy clinic. GPs are able to contact the heart failure clinical nurse consultant if at any stage if concerned or if they have any questions. Primary care here is a key part of the model of care. So just looking at the key measures of success for these projects is we're looking at 30 and 90-day unplanned readmissions, and we're actually looking at all cause readmissions here. We're also monitoring the length of stay. There are a number of process measures also of particular interest are the 48-hour phone call for patients, and as well as patients where the discharge summary is transmitted to the next site of care within 48 hours. And we'll just briefly touch on some of the data that we've been collecting. So this is all manual data collection looking at 30-day all-cause readmission rates, which as you can see varies quite broadly across the general medicine and cardiology units. We're also looking at the 90-day readmission rates. As you can see, given manual data collection, we don't have quite enough data points to make any assumptions or comments as yet. And just looking at the length of stay as well, which as you can see also varies quite broadly across the units and from month to month. So our next steps is ongoing collaboration with GPs, and we're aiming to create a standardised discharge summary template, which will include a clear medication up titration plan for the GPs to follow and to use alongside the clinics. We're increasing collaboration and support with general practitioners, and we're also looking at ways of improving communication through our digital platforms such as Health Hub, Parkfield Connect and Care Companion. And I'll also just briefly talk about the Heart Helper project, which is our third Safer Care Victoria project, which is still sort of getting into the implementation phase. We're just organising at the moment still. But looking at the aims and objectives, we're looking at developing and trialling a home-based model of care using a combined or alternate workforce to help support people living with heart failure after a recent hospital admission. And the main outcomes of this project are going to be reduction in unplanned hospital readmissions, as well as a reduction in emergency department presentations for heart failure patients. We're also hoping to improve patient-reported outcomes by looking at their experiences, symptom improvement, and quality of life, and their ability to manage at home. So the main objectives are we're looking at implementing and evaluating a community-based model of care through home visits where the healthcare worker will assist in telehealth setup, individualised care plans, and supporting acute to community transition for heart failure patients. And this will also be by June of 23. We're also looking at implementing and evaluating a 12-week telehealth cardiac rehab program for these patients with a designated cardiology physiotherapist, including exercise and education. And we're looking to further expand the multidisciplinary team to include general medicine and cardiology pharmacists who will also be involved in telehealth appointments for these patients. So just looking at some statistics of patients who attend heart failure rehab, the data shows a low referral rate for our patients to a heart failure rehab service, and also that many of our patients have barriers to attending heart failure rehab, with many of them from non-English speaking backgrounds, as well as living rurally or living at home alone and elderly. So our current RMH heart failure rehab pathways, so we have a face-to-face option with cardiomyopathy rehab. We have our Melbourne Health HARP program, which does both face-to-face in the home as well with an allied health assistant, and otherwise external HARP and external heart failure rehab services. There are many pathways, as you can see, which will be continuing. However, we've increased the number of heart failure patients being recognised through these projects, and each of the Melbourne Health heart failure rehabs are currently at capacity. So there is a lack of specific heart failure rehabs in Melbourne, and the poor uptake of rehab due to accessibility, among other issues. Heart Helper will aim to address this issue and ensure heart failure rehab is accessible to a greater cohort of patients. The program will be home-based with in-home support to assist with technology. And just some contact details for myself and Joe, so that if you ever need to get in touch with us, we have an email address that reaches both of us, or you can always contact us on our mobile numbers. Thank you.
Great, thanks so much, Jess and Joe, for that presentation. So we've got now a few questions in our Q&A box. So these are a couple of questions for James. So James, a really good question here. So what happens if the patient's blood pressure does not allow the up titration of all the 4 types of heart failure medication? Should we continue to up titrate as long as the patient is asymptomatic? Or should we target a minimum blood pressure, for example, 100 to 110 millimeters of mercury? Or if their blood pressure only tolerates an ACE inhibitor, should we just leave them on an ACE inhibitor? So really interested to hear your approach, James.
Okay, good question. I don't think there's a one answer that fits all here. I think I would try to get their blood pressures to a lowish level, not to a point that makes them fall over and feel very dizzy. That's the end thing that you don't really want to get down to. Surprisingly, ACE inhibitors, ARBs, really maintain cerebral perfusion despite having a lower peripheral blood pressure. And so that's why a lot of people do feel reasonably well with a blood pressure at 95 or 100 systolic sometimes. And I don't mind nudging them slowly down to those levels, so long as we do it very, very gently and know that they're going to be fine with it. So as long as they seem to be reasonably asymptomatic, that's a good thing. Obviously, we don't want to take big chances and give them big doses of anything. And I think if anything, you want to proportionalize the agents which all lower blood pressure, that being the beta blockers, the Entrestos or ARB ACE inhibitors, and the MRA. So in the order of the bangs for your bucks, obviously the beta blocker would be up front, and you'll be using most of your blood pressure room in that sphere, and then secondarily with the ACE ARBs, Entresto number 2, MRAs number 3. The SGLT inhibitors don't really muck up your blood pressure much at all, so it's a good thing to nudge that along aggressively and get them started with that. And the other drug that's also useful, if particularly when the heart rate's actually quite fast, is ivabradine, which doesn't really affect the blood pressure at all, just affects the sinus heart rate in that way. So it's not a single answer to everything, but that's in general principles where I would take that next.
Yeah, that's fantastic. Thanks, James. And so then also a question about HFpEF. So if the echo is normal, but the patient or the client has got symptoms and risk factors, so there's an assumption of HFpEF, and they start treatment, how do you assess improvement? Is it just improvement in clinical symptoms?
Largely that is the case, actually. So when we see HFpEF, there's often something on the echo that might give you some suspicion that something's not right. It's not just a normal left ventricular ejection fraction that we stop there and call it HFpEF. We may get some clues, with the left atrial pressure being elevated, and there is a little number called the E to E prime ratio, which is probably not something that is well known to a lot of GPs, but we use that as a measure of left atrial pressure or filling pressure. And sometimes if that number is elevated, we have a higher suspicion something's not right. They may even have left ventricular hypertrophy, an enlargement of the left atrium, or sometimes pulmonary hypertension. So they're the subtle clues that there is something not right about their heart function at that time. In terms of how you gauge that function-wise, I think the best thing is ask the question, how do you feel? How far that they can walk sometimes on a flat road without stopping? How quickly that they can recover after having done something as well. BNP is a useful test, and it does match up with how the filling pressures are going. So, particularly when patients might have a combination of problems like airways disease and heart failure, and they present to you with symptoms of breathlessness, which is going on there? It could be one or the other or both. And sometimes if you do a BNP when they're sickest and do a BNP when they're wellest, and then if they do decompensate again, then you'll get an idea which direction to take that lead next time round. But certainly, the clinical signs of JVP elevations and the actual pulmonary congestion seen on X-ray are also other valid ways of looking at that too.
Yeah, great. Thanks, James. So a question for Jess and for Joe. So on the discharge summary, do the medication lists on discharge given to clients mention that the dose of some of the medications are likely to increase? So could pharmacies be informed that dosages are likely to increase over the next few weeks? Jess, does that, would you like to comment on that and some of the work that you've done with the improvement projects?
Yeah, so we're still, it's still a work in progress. So on the discharge summaries that get sent to the GPs or the next site of care, we're working on, like a template where the up titration plan is on there, and that can also be sent to pharmacists. But the ones that go home with the patients are a little bit different. So they probably don't go through the changes as much, but it is certainly something that's discussed with them during their medication education by myself or Joe. But it's certainly something that is being worked on as well.
Yeah, okay, great, excellent. And excellent, so that is all the questions in the Q&A so far, but please keep them coming. So now I'm delighted to then introduce Sue and Leanne, where we're going to now have a discussion. But firstly, I'm going to put up some slides that Sue will go through on what is currently available on different sort of tech platforms for us to communicate with primary care. So I'll just share these slides.
Welcome, I'm Sue Hookey. I am GP Liaison at Royal Melbourne, and you're very welcome to contact GP Liaison. Our contact details are on the RMH website, and under under Health Professionals GP Liaison. So if ever you need to contact us, please go to the Melbourne Health website. We'll go into Health Pathways, and Health Pathways has a GP Liaison page. So we're going to talk about how we can improve communication between the hospital and the GP, and part of that is our solution of the Health Hub and Parkville. So we wanted to know what people coming knew before we talked about this, and we found that not that many people know much about Parkville Connect. So very few of the GPs who registered knew much about how to look up access to medical records, and also patients knowing what the Health Hub is. So the Health Hub is the patient portal, and Parkville Connect is the provider portal. So again, when heart failure patients are admitted to hospital, GPs are not that aware of the discharge summaries being available within 48 hours. So we actually hope that it's much better than that, because in our internal audits, we at least have 86%, is because we have easy way to monitor that these days, but the perception is that they're not coming. And that the patients with heart failure, the discharge summaries have a clear medication list, and certainly that seems to be improving in the perception in this group. Next slide, please. So just to update you a little bit about Health Hub, hopefully you've got some patients who are aware of Health Hub. And Health Hub is the patient portal which can be accessed through a mobile phone or on their computer through the web. And your patients, consumers, or their proxy, if the patient gives permission to the proxy, can access that health record. And they can use that to interact with some healthcare professionals, or sometimes with the particular clinics that they might be going to, and contribute to some of their care. So they can keep diaries, they can do various things depending on what the clinic is doing. I know things like some clinics at the hospital are now using them for surveys, and I'm not quite sure what degree the cardiology team are using this. But the really important thing for you as GPs and clinics to know is that the patients can actually, if they activate their Health Hub, can see when their appointments are, and there is some capacity to reschedule appointments, and they can view their letters, outpatient letters, and if there have been some notes put into their files. So after a certain amount of time, some pathology and imaging results are released. After, hopefully, if there are any distressing results, they can be conveyed to the patient. So there is a delay between the tests coming available to the doctors and the patient being able to see it. There is some capability that we are working on about some messaging, but we're still working on that, so I wouldn't be using that as yet. But the questionnaires is something that some people in the hospital are using, and really important for you to know that if your patient has activated Health Hub, they can share their record with you while they're in the clinic. So if you want to know something, you can ask them to show you through their Health Hub access. Next slide. So patients are being given the opportunity to sign up to Health Hub when they're actually having an outpatient appointment, when they're in ED. Last year, they would have been potentially coming in for COVID screening, and to get the results, they also were being given the option to sign up to Health Hub. So there are a number of different points of contact with the hospital that we encourage patients to sign up to Health Hub. And if you are getting a patient who's signing up to Health Hub, it's a bit hard to see this on the slide, but it is done through SMS. We're trying to really make it much easier for patients. So just if they are, just let them know that there will be potentially a text that will come, and they can activate it through this text when they've been at the hospital. Next slide. And so patients can actually share their record with you. So it is a really useful tool. So you in the clinic, if you're not sure about something, can ask them to access their Health Hub and show it to you. So we do have a video.
My feelings. I'm feeling much better since we started managing all our work on Monday.com.
Have you ever picked up your medical record at one clinic just to bring it to another doctor? Or asked the family doctor to fax, yes, fax, a document to your new specialist? MyChart makes it easy to share your medical information with everyone who helps provide your care. Most of your healthcare providers probably already have secure access to your health information. But let's say your chiropractor doesn't have access to your chart. Use the Share Everywhere feature within MyChart. From your phone or computer, log into MyChart and find Share My Record by searching the menu. Or at the bottom of your homepage. Request a share code, enter the name of your recipient, and you'll receive a one-time code to share with them. As long as the recipient knows your birth date and can access shareeverywhere.com, they can see your record. Worried about security? Your recipient's access lasts only for this one session. You've seen how to share your record with others, but there might be situations where you need continual access to someone else's medical record.
So that's just a way that you can help guide a patient to go through that section. So just going on to Parkville Connect. So Parkville Connect is the provider portal, and it's a provider portal for the Parkville precinct. So that's Royal Melbourne, Peter Mac, the children's and the women's. And ideally, every GP can get access if you need to be, firstly, you need to be on the National Health Services Directory, the NHSD. And ideally, one person in your practice who loves administration is going to coordinate access for all the doctors in your clinic. So that might be the practice manager or the practice principal, but it needs to generally have one person to coordinate everything for your clinic. So when you register for Parkville Connect, there is a process. It will take a few weeks, but when you do have access, you can look at, you have a read-only view of the patient's electronic medical record at their Parkville hospital. Important to know, though, that you have to be registered as the patient's doctor. So really encourage your patients to carry one of your business cards or to have in their phone your name, your clinic name, and the address of your clinic. So it's like you've got 3 points of identification, because sometimes GPs work at different practices. Sometimes there are practices with similar names or in the same street. So it really helps to encourage your patients to know your name, the clinic name, and the actual address of your clinic. So it helps us get the information to the right GP. And that means that if the patient records you as their GP, then you can see their file if you're registered on Parkville Connect. So you can see the discharge summaries and results. So if you get one of those horrible discharge summaries that says GP to chase results, hopefully you'll be able to actually see them on Parkville Connect. We are trying to get clinicians not to say chase results, but we are working with the hospital on that. So there are some other capabilities in the future, but not yet. So the main ones are the information that you can access in that first point, and the others are works in progress. So next slide, please. There are some instructions again on how to access the patient information. So that's just where you can go to review the information. And the next slide is, if you go to the website for parkvilleconnect.org.au, there is a couple of drop-down boxes on login and sign up instructions. So this is the instructions that you get when you go to the sign up page. And it does take a little while, so you won't be able to get it straight away. So that's why we encourage you to do it in advance, and in the meanwhile, use Health Hub so that you can look at it from the patient's aspect. So we have a question. So a pharmacist working in a GP practice cannot access Parkville Connect because they will probably not have NHSD listing. So if you, Laura, want to get in contact with me at GP Liaison, we can try to work out something. But often it's because certain practitioners are not on the National Health Services directory. You have to be on that. That's what we do to verify that you're registered and all those sorts of things. So hopefully if you email us at gpliaison@mh.org.au, hopefully we can help you. All right. That's the last of the slides, I think, Sharon, isn't it? Yep.
Yes, that's the last of the slides. So so at this point, this is the QR code just to provide feedback on the presentations. But at this point, I'd like to invite you all to unmute. And I would like to invite some discussion now. So, led by Leanne and by Sue, where we're really keen to hear from you, from primary care, about the management of your heart failure patients and what we're doing well, how you think we can improve. And we're really keen to hear your thoughts. So I'll just stop sharing these slides.
Just make sure people get a chance. First, do your QR code, everybody.
Yes.
And there might be an email that it'll give you if you miss out on the QR code, but we'd love to see your smiling faces.
So I'll just leave that there for another moment.
So I might just cut in there while people are getting that. I think we're starting to get some Q&As, but I guess you can see that we're trying to do a lot of work on the heart failure group. We did have a lot of problems with our heart failure service, and we know that there was delays in getting outpatient reviews. But one of the things that we're really working on is that transition period, that 3 months after discharge from hospital. And one of the main areas we're trying to do is improve communication with you, with the GPs. One of the things that we're doing and encouraging, and I really like your feedback on it, but we are encouraging our heart failure patients to have one GP and one pharmacist so that we can improve communication to and from. We do find it very difficult if there is multiple GPs and multiple pharmacists, and our pharmacist is starting a new project where they'll communicate the medication list with the pharmacists, hopefully arrange a Webster pack for the before discharge from hospital, and update their medication lists in the health hub section. So perhaps, I don't know if anyone's got any feedback about whether asking them to have one GP and one pharmacist, do you think is a good idea or not a good idea?
So, Jen, have we been able to unmute our participants?
I've just given them the option to unmute if they want to chat.
Certainly, it is fantastic if patients, in ideal world, can get an appointment in a couple of days after discharge, and certainly RACGP is really keen to make sure that people get hospital appointments after they go to the hospital. And it really does make a difference when you've got a relationship with the GP and the pharmacist, and if we can all consistently give the same message, because sometimes patients are not aware that the continuity of care generally will give them better health outcomes. So it's really, I keep on trying to emphasise to patients, this will give you a better health outcome if it's one person who can see if you're deteriorating, if you're getting better, and some of them just don't understand that. And if our receptionists can also give that message as well, ideally see the same patient when you can in the GP clinic. And if you want to ask a question, if you raise your hand, use that raise hand on the bottom of the screen. That's just to the right of the green share screen button. If you'd like to ask a question, please. Or type it.
I guess the other thing that we're really asking in these heart failure patients is that they have an early appointment with their GP. So at around a week post-discharge. So they'll have their heart failure nurse contact them at a couple of days post-discharge, and they'll have a telehealth outpatient appointment in 2 weeks after discharge. But we'd love them to see you at around the 7-day mark. And I just wonder how feasible that is in the majority of patients.
Would somebody like to contribute from our GPs? How would that work in your clinics?
Yeah, we're really keen to hear, because we're finding, certainly from the wards, our patients are telling us that it's difficult to be able to get a GP appointment soon after discharge. So we've had a comment here that it's easier post-COVID.
So some practices encourage patients with multiple chronic illnesses to have regular appointments, so it's not fire going from disaster to disaster and just a keeping you well appointment. How is that working in the community? If somebody had some regular appointments, how often would you say they'd need to be seen, James or Leanne, to keep on top of all of this?
A difficult question to give you a straight answer for, Sue. I think, I guess it all depends on how brittle this patient really is. And I think, if anything, if they are quite brittle, they become more needy, I suppose, in the sense that we need to see them more frequently and sooner as well. So I think I'd like to keep that sort of option to be quite variable, if that makes sense to you. I think I don't think there's a standalone. I mean, there are people who are very, very stable and well that probably don't need to make a change or see GP for several months or even a year sometimes, if they're actually very, very good. But there are those who are actually quite brittle. And if they are that way, I think, even a monthly level would be a reasonable thing to actually go for, really.
Yes, I think in the patients after discharge from hospital, that first visit around the 7 days, and then I think they will need monthly appointments for the first 3 months. And then, for instance, with our program, that'll sort of tailor very well with the outpatient appointments that they're having. And we just have another answer to say that appointments are readily available, which is, fantastic.
Sometimes I find that there are patients who might see a different GP in the same clinic, and they often be happy to do that because that's the next available person that they can sometimes see in that particular clinic at that time. Is that going to affect how we think about that, Leanne, in the sense that we'd like to have the one doctor? Is it the one doctor or the one clinic that is the entity there?
So you might be able to help as well, but my understanding is that we only can list the one GP on Epic that gets all the information. And so if that's the case, as long as there's very good sharing of that information within the GP clinic, I think it'll be fine. But I think we just need to make sure that access to the patient information is, able to be well shared within the clinic. But I would see that would be quite feasible.
Yeah, certainly the records in a clinic, if they're kept well, should be sufficient for good handover between doctors. And certainly in the GP training programs, we're always encouraging the GPs to make notes that will mean that if somebody else is seeing the patient after them, they understand what the management plan is and what the doctor was thinking, and hopefully with your action plans. So will the action plans be sent to the GP as well? So like the discharge summary, or will that be something the patient has?
So yeah, Jess, do you want to answer? It's going to be on the Health Hub, and so we're hoping that there will be access to it through the Health Hub system.
So at the moment, the action plan we give the patient is given to the patient in their after visit summary. We haven't included it in the standard discharge summary yet, but it is. I mean, it could be something that we look at. when we're writing our discharge summary templates or designing that?
I think I would highly recommend that, because then everybody's on the same page. Because if the patient comes in saying, you know, I'm meant to be seen, I need to be seen quickly, and it would be helpful if the GP actually knew what the patient was responding to. Because if it is a tailored one rather than it being a generic one, that would be really important for the GP to know why the patient was needing to be seen. So if that could be included with the discharge summary as an addendum maybe, or when you're printing out the after visit summary, if a copy could be routed to the GP, that would be really helpful, so everybody knew the same thing. Also, with different levels of health literacy and people are unwell when they're in hospital, if the GP gets a copy, they can emphasise what's important. They can remind the patient, and they can translate things that the patient may not understand. So it's really a full education tool for the GP to have it as well.
Yeah.
We'll certainly take that on board. Just one other comment is that we are doing B&P on all patients now with heart failure in hospital. So one of the things that we find difficult is sometimes making sure we've got the right diagnosis, particularly in the HFpEF, the ones with a normal ejection fraction or a mildly reduced ejection fraction. So I think this will become a lot clearer. It's something that we've only recently introduced, so that it's absolutely routine in all the heart failure admissions, so that they'll have a more definite diagnosis. We know that sometimes people with shortness of breath, you know, can have a variety of causes of that. So I'm hoping that will sort of not eliminate, but reduce the need for sometimes the B&P to be done outside when the patients have to pay for it.
I'd also be really interested to hear whether GPs, you know, anyone on this webinar, whether they've seen a patient who's attended our telehealth clinic, whether they've been involved in that and how they've found the communication from the telehealth clinic, or also how they've found contacting us if you've had a question about your heart failure patients. So, you know, finding information about how to contact Jess or Joe. You know, if anyone has got any comments about that, that would be really, you know, fantastic.
So press the raise hand button, which is just to the right of the share screen, or type something. We would love to hear from you. This is your great opportunity to give us some feedback to our amazing cardiology team, and who knows, you could help create some amazing positive changes.
But we'll certainly take on the action plan. That's something that we can do and will do.
Sue, do you think there are other pieces of information in the discharge summary that you'd be wanting us to include? I know the action plan you mentioned, information about drug titrations and things like that. Is that a useful thing to include? I know it's a bit complicated because everyone's got to have a little different way of actually titrating drugs based on how brutal they may be, but does that help things out there for you?
I think certainly if there's even just some indication that it is needing to be titrated, and if you've got a document that you can add to that, or a place that we can go to look at if there's a reference to that. But ideally, if it's all in the same document, everybody can look at it at the same time. So GPs are time pressed, so if they've only got 15 minutes. So Nadia is saying she can't unmute herself. So I thought we were meant to be muting people.
I've just given permission. It's just a bit harder in a webinar setting.
Okay. And I've lost my track. Yeah, but certainly knowing if there's a place that we can go to, that we can get the information. But if the patient knows, the GP knows, and the pharmacist knows that there is going to be a change in medication as things the condition changes, that's really helpful, because often we all need to be able to back each other up on what's needing to happen next.
Yeah. I mean, there were some feedback comments in the surveys. So, you know, there were comments about written heart failure diuretic action plans, clear steps for medication titration, regular education for GPs, easy access for specialist advice, you know, easier access for Parkville Connect. So a few comments like that were coming through. Don't know whether that... so there's a question here from Dominique. Is there a pathway for investigating the underlying cause of heart failure? So James and Leanne, do we want to comment on that?
So health pathways, look at health pathways.
Yeah.
Yeah, the health pathways, I've only had a look at it since yesterday because I signed up to get access to it myself here. And it is actually quite a wonderful document, and it's worthwhile getting down there and just digging into that, because it does talk about what are the underlying causes for heart failure and what are the underlying things that can be tested for outside. Sometimes a patient may not be very sick, you know, they may be mildly breathless, but you are diagnosing heart failure. Then if you some GPs I find are very keen to start delving into that area and start to investigate on their own accord, and then to actually refer the patient on accordingly. Some GPs I find would be keen to refer very early in the piece and let us handle that question, but there are GPs out there who would give me a call and say, what kinds of tests would you want to do next? And then that way we can get the ball rolling before we get to see them sometimes as well. So I think all of those things we'd like to meet your demands, I think, as you know, for the GPs out there, and we'd like to work with you in that way as well.
And just a comment, I think the HEF-PEF is sometimes really difficult, and I view it as a diagnosis, not a diagnosis when nothing else fits. So it's really important, I think, to get the right diagnosis when it's HEF-PEF. And as James was saying earlier, the echo can be quite helpful here. You know, in about 45% of cases, it's associated with atrial fibrillation. Hypertension is also very common. And the echo, hopefully, if there is evidence of raised filling pressures, it will be reported in the conclusion as evidence of raised filling pressures, and that's very suggestive of HEF-PEF, or there might be left ventricular hypertrophy or biatrial enlargement. But if you're uncertain, I think this is where BNP is actually really helpful, because if it's less than the 100, then it really isn't HEF-PEF, and then we need to treat differently than if it's an abnormal BNP. So that's when they've got a reduced ejection fraction, it's a bit easier, but this is where the BNP is really helpful.
Yeah, absolutely.
And we've got a reminder from some of our participants about abbreviations. So a lot of the hospital departments get used to using abbreviations and forget that people in the outside world are not using them the same way you are. As earlier VAD, I was thinking, what's voluntary assisted dying doing in there? So it is Drop the Jargon week. We had Drop the Jargon Day, and the EMR does actually have a dictionaries facility that you can use to get your abbreviations spelt out in full. So I would really encourage the cardiology team to embrace using the dictionaries facility in the EMR, and that will, while you're typing, make those abbreviations spelt out in full. And you will win a lot of fans in the community.
Great, fantastic. And I just saw that Jess responded to a question about the Safer Care Victoria and whether the model of care is in other hospitals being, and Jess has responded to that. Thanks, Jess.
So for the recording, what was the answer?
So the question was, is it just RMH or other hospitals using this great model too? And Jess has responded, Heather, great question. The other hospitals participating in the Safer Care Victoria projects are designing their own models of care to meet the needs of that service. So thanks for that question. And there was also a comment about titrating information would be great for GPs in the discharge reports. What do we think about this?
So that's certainly our plan, isn't it, to put that in the discharge summary and a clear plan. So with the telehealth outpatients for the first 3 months, we hope that we will be able to work with you to complete the titration, the up titration during that 3 months. Sorry, James, are you talking? But also there will be a plan of what we're aiming to get to, what they're discharged on, what doses are we aiming to get to in that particular patient, because it will be different depending on their, particularly their renal function and their blood pressure.
Yeah.
That's certainly coming. It's going to be introduced in the next couple of months.
We have a question about what is MRA in terms of treatment?
MRA is the mineralocorticoid receptor antagonist, so things like spironolactone and those kinds of drugs, which would be the most common MRA out there right now. So I think it's important to note that of all the diuretics, there's just 1 or 2 diuretics which actually have prognostic value. That's why we're pushing that upwards. So things like furosemide, thiazides, they actually do decongest patients, but they don't actually improve their longevity or mortality. So the MRAs are important to improve that side of things for them.
Great, thanks, James. So I think this has been, you know, a great discussion, and we're now approaching, we're just 5 minutes to 8 now. So thank you to all of our speakers, and thank you to the Primary Health Network for helping us set up this webinar. I hope that all of the participants have found this useful. And please provide your feedback. We really look forward to hearing your feedback on the webinar. But also, please do communicate with us. Please contact us. Let us know what we're doing well, what we can do better. We really want to work with primary care to improve the treatment of our heart failure patients. So thank you very much, and have a good evening.
And I've just got one last question.
Yes.
So advanced care plans, do our clinic, our nurse practitioners, are they suggesting people consider an advanced care plan or see their GP for these things? Because I know we'd love to say we're going to save everybody and give them a very long life, but it is always something to consider, and GPs sometimes need patients to have something to suggest it, and it's only then that they'll follow through. So is the hospital encouraging people to get an advanced care plan?
Jess or Joe, do you want to comment?
At the moment, we the social worker sometimes touches on advanced care planning with our patients, and I think it's something that we're going to be working on as well in the future.
Okay, thank you, because it really helps if somebody else starts the ball rolling and then the GP doesn't have to be the bad guy. You know, they're just following through. So it really helps if we all can support each other to get patients to think about what their wishes would be if they cannot speak for themselves. Thank you.
I will say as well, in our clinic, it has been touched on more from the medical staff so far, while we still develop that from a nursing side.
Yeah. And yeah, thanks for raising that, Sue. That's certainly something that we're looking to do better as well.
Thank you.
All right, so thank you everyone. Again, thank you to the presenters and also to the participants, and we look forward to hearing from you and working with you more in the future.